Bob asked me to talk about PED from the point of view of the diagnostician, so I'm going to share some thoughts on diagnostics. There will be a few slides I will skip because it's been pretty well covered. So I think we all understand up to that part there. But in terms of diagnostics, a few things that are important to understand. I'm going to try to explain what kind of diagnostics we do and why. The virus replicates in the epithelial cells of the small intestine. So those are the epithelial cells there in an immunohistochemistry labeled with an antibody for PED. The incubation period is between 1 and 2 days, and shedding in feces, at least from the reports that are out there now, we believe it's between 7 and 11 days. It might be a little longer based on the clinical observations that we're seeing now, but this is what we knew when we started working on this disease. And we also know that there's an immune response created against the virus, and we get serum antibodies between 7 and 14 days post-infection. These are some pictures from ASV that you probably have seen. So the disease, like we heard, causes very high losses in the farrowing rooms, then in the nursery, and finishing. We can see diarrhea, or in some cases in the finishing, we might not see diarrhea. So that's going to complicate a little bit the diagnostics. The good news, though, about diagnostics is that for this disease, we don't need to do anything completely different from what we usually do to diagnose diarrheas. So we have to follow the same basic guidelines that we do for diarrhea. We would like to select live, acutely affected pigs with diarrhea, and do necropsy on those pigs and collect samples hopefully within 15 minutes of euthanasia. So we always know that that's sometimes a challenge, but as quickly as possible. And that's for PED, but that's in general to diagnose diarrhea. So every time we're diagnosing PED, we might be wondering what else is there, or if it's not PED, what it is. And doing good sampling in the farm is going to help us in the lab figure out what it is. In terms of gross lesions, we heard about how we can see thin-walled intestines. I put a question mark in there because to me that's a hard call to make. And sometimes you see it, sometimes you don't. Definitely if you see it and it's very clear, it might help, but don't expect to see it every time. Actually, just to show you an example, I don't see very much in the gross lesions, just liquid intestinal contents. And just as an example, we did some inoculations of pigs, and we inoculated PED into pigs. We saw in 24 hours we were seeing diarrhea. We euthanized pigs in 48 hours. We had positive controls, negative controls. And I thought, well, I'm going to take pictures of these gross lesions, and I'll be able to capture the thin-walled intestines. Well, it didn't really work. Those pigs that had a lot of virus, they had diarrhea, they have very low CT, PCRs, they basically didn't have the clear thin-walled intestine. So I'm not saying it's not a valid observation. I'm just saying be aware that it might not be there. Then in terms of sample collection, we want to collect small intestines. We want several sections. I think if we collect 6 sections trying to represent the whole length of the small intestine, we would be pretty good. We would be able to cover both ileum and jejunum. And we would like a longer segment sent fresh and a smaller segment sent fixed in formalin. And other than that, it's a diarrhea, so we would like to receive colon too, but also we're going to try, when we get tissues, to rule out other diseases and to look at co-infections. So a complete tissue submission is always going to help us. So what are other sample types that we are testing for PED? We're going to work with, we've been working with feces, with fecal swabs, with oral fluids, with feedback material. Well, these 3 up here would be more to diagnose PED cases, and then to work on some of those already PED diagnosed cases. We've been working with feedback material, environmental swabs, and feed. So those are all samples that we can work with. So when we get all these samples, what are we going to do? We've heard already that virus isolation for PED. It's difficult. It's difficult to grow. So that's not going to be our first choice. Electron microscopy in general for coronaviruses has low sensitivity. So we're going to go, for the routine cases, we're going to go with histopathology, and we're going to be looking for the typical atrophic enteritis that we see with viruses. So here you have an example. These are the villi of the jejunum. And you can see how short they are. This is a case of PED. They are supposed to be long and thin, and they are very, very short. So that's what we're looking at. Unfortunately, that's the same thing that we see with TGE and rotavirus. So it's going to give you an idea, it's going to give us an idea that we're dealing with a virus, but we need to follow up with real-time PCR. And this is basically what we're doing now. For diagnosis, we're using histopath and real-time PCR. And PCR is sensitive and specific. It's already available in laboratories. So that's mainly what we're doing. A few more pictures of the kind of lesions that we find. We see this necrosis in the tip of the villi caused by the virus. Very severe. Typically, I see these lesions more severe in PED than in TG and rotavirus, but it will also depend, of course, on the timing on the infection on every pig. And we see that flattening of the epithelium, the vacuolation of the epithelial cells, very characteristic for atrophic enteritis. Look at this other cross-section of the intestine. The lumen is pretty much empty. In a normal pig, we would have all these villi projecting inside of the lumen, and here it's pretty much lost. It's very, very thin. So even with these gross lesions, let me go back to the comment on thin-walled intestines for gross lesions. Even with this type of severe microscopic lesions, I wasn't able to see this thin-walled intestine lesion grossly. When we put the antibody for PED onto these lesions, we see a lot of cells with a lot of staining for PED, and this correlates to what Dr. Dufresne was just saying about the amount of virus that we see in these cases. There's a lot of virus. For some other viral diseases, you would see just a few cells turning positive, and we would be happy with that to be able to diagnose viral diseases. With PED, this is what we're seeing. A lot of virus, and here is just another picture to show you that I wasn't just picking a pretty section. It's pretty much wherever you go, you're going to find a lot of virus in these severely affected pigs. So that was immunohistochemistry. We can also do in situ hybridization. Those techniques are going to help, but they are typically less sensitive than PCR. So again, we are going with PCR for routine diagnostics, but it's good to have immunohistochemistry for research, for retrospective studies, and also if we want to receive samples that for some reason are fixed and we don't have the unfixed samples. And then serology, I think when we get good serology and we understand the limitations of it, is going to be very important for this disease. Of course, it's going to be indicative of previous exposure, so we're going to use it more on unknown cases or more chronic cases, but it's going to help a lot. First will be IFAs or IPMAs. ISU already has an IFA available. We're working on ours at Minnesota, but hopefully we'll be able to develop an ELISA. An ELISA is always easier and faster to run, and to run a lot of samples at the same time. So there are several groups already working on the ELISA. Now, what are the testing protocols that we're using? We're learning as we go on this, but when I say testing protocols, I mean what kind of pigs do we select, how many samples, what kind of samples. We have all these options, right? So it's going to depend really on what we want to do and what kind of case we have in front of us. And it's hard to put together very specific guidelines, but one of the groups that the National Purpose helped put together on PED biocontainment came up with recommendations for what kind of samples and how many to take, and this group includes diagnosticians like Dr. Madsen and Dr. Schwartz at Iowa State, and veterinarians like Dr. Dufresne. and I'm in that group myself. And so what we came up, and this is a little bit also based on my opinion, if we have farms with diarrhea, my preference is getting tissues from acutely affected pigs. And then you can target your diagnosis to the pigs that are showing diarrhea. And we talk about, which tissues and what we're looking at in those tissues. But then another alternative would be to use fecal samples. And at this point, we think that we can work with 15 fecal samples in pools of 5. We feel comfortable with that pooling strategy. Maybe as we learn more, we will have to refine those recommendations. Especially in the nursery and finishing pigs, oral fluids have been used too, and so we are at the point that we have recommended 2 oral fluid samples. And again, this might be refined once we know more about the disease. We've worked mainly so far with acute cases, and now as time goes by, we start having these farms that are not acute anymore, and we have to evaluate those diagnostics more for that type of farm. Now, when there's no diarrhea, what do we do in farms that there's no diarrhea? We don't think, or at least I haven't heard of any sow farm that gets infected and there's no diarrhea. So here we would be talking mainly about finishers that can be actually positive and don't show diarrhea, or don't show diarrhea to the level that would raise a red flag. But we might want to know if those are positive or not. Again, fecal samples, we can do 3 pools of 5 for a total of 15 samples. Oral fluid samples, these fecal samples, we will try to find the loosest pigs. But like I said, if there's no diarrhea, we might not find pigs with diarrhea. So in this case, oral fluid samples might be more beneficial. And finally, serology. Remember, for serology, we're not going to pick the very, very acute cases, but it might show up that those pigs were exposed to the virus before. And finally, what are we going to do in those farms that got infected in May, in June, that went through the whole outbreak, and now they are getting recovered, they are back to normal in terms of production, but we think they might still have the virus? How are we going to be able to tell if those farms are still positive or not? Serology probably won't help us much there because we know those farms are positive. So we're now working on PCR in piglets, and as a starting point, we started with fecal samples, 30 samples in pools of 5 from 30 different litters. Eventually, serology on sentinels might work, but most of the farms, they are not at the point where they are introducing negative gilts. And just as an example, here we have an example of a farm that did some testing. 8 weeks after clinical signs, they got 10 out of 10 positive. This is on piglets in the farrowing room. And then we went with the 30 samples. In this case, we're doing individual because we want to learn a little bit more before we go into the pooling strategy. But 12 weeks after the clinical signs, they already were down to, they were at pretty much normal production, but they still had 7 out of 30 positives. And then 14 weeks after clinical signs, we still picked up 1 positive out of 30. Those samples here are with CT values between 20 and 30. So we think if we had pulled these samples in pools of 5, I think we would still have picked it up. But this is an ongoing effort in trying to figure out what's the best way to pick up the virus in this, if it's still circulating, pick it up in these previously positive farms. And then very quickly, let me just give you a little summary of how the outbreak went for us at the diagnostic laboratory and what it meant. The first cases, as you know, they were observed in May. This is data from Minnesota, and we very quickly developed a PCR for it. We started testing pretty much every day. This is the same graph, but cumulative. In 2 months, we have over 100 positive submissions right there. This would be the negatives, and those would be the positives, and this is the cumulative. Here is a little bit of a more objective slide or something that I wanted to share with you, because I've heard several people saying that this outbreak showed clearly that because it spread so fast from one farm to the other, it showed that we were not ready for a foreign animal disease, or we were not ready for this. And I have to disagree, at least in some part, with that statement. This was a very, I would say, difficult to control and tricky outbreak for some of the reasons that have been commented already. A very high amount of virus. It would make a lot of sense to think that this virus would work similar to TGE, and yet we've seen that it didn't really work like TGE in all the cases. And from the VDL point of view, I think that we, in two different diagnostic labs, we identified the disease very, very early. We went back to some of the samples here, and we didn't find any samples before the original samples that we found. Iowa State tested a lot more samples from the beginning of the year, and they only caught a couple cases 1 or 2 weeks before the index cases. So I think we caught it really quickly, and we developed PCR tests and real-time PCR tests that give you results in 24 hours very, very quickly too. So in that regards, I think in this country, at least for the system of veterinary diagnostic laboratories that we have, reacted very quickly. And then also the different universities, the USDA, ASV, National Pork Board, everybody got involved very, very fast. In my job, I have the opportunity to interact with diagnostic laboratories and production companies from other countries, and even regulatory agencies from other countries. And I have to say that I think we're pretty well positioned. Yes, there's things that could have been done better, perhaps, but I think the response from all angles was very good. It's just a very challenging virus to deal with. And then to finish, what we did, so we were monitoring up to a certain point our results, and Iowa State was monitoring their results, and then from an initiative from Dr. Main, we decided to combine ISU results and Minnesota results and get a common database to figure out what was going on. So that went very well, and the ISU maintained that database. Eventually, that got transferred to USDA APHIS and the National Laboratory Network, and now we're getting a weekly summary that most of you are familiar with that weekly summary. So basically, we have weekly information on this disease, on what's being collected in all the laboratories. So again, the collaboration with universities, USDA, ASV, National Pork Board, in this sense, has been pretty amazing. And so this is a summary of this weekly data that Dr. Ackerman puts together every week. Most of you are familiar with this. So I would just want to stress, the collaboration between all the laboratories and USDA, and how, if you think about it, we don't have this for any other disease. We don't have this for PRRS. As bad as PRRS has been for many years, we don't get to this level of data inclusion from laboratory results for any other disease. At the beginning, we thought this data was pretty representative of what was going on, how many farms were infected. So this is every week, the results for every week, and this is the cumulative. Now what we're seeing is that we think that some of the farms that got infected earlier, they are starting to retest, and so we're getting a probably less accurate database. So there's a lot of limitations to that database that we are trying to fix, but again, it's something that we didn't have for any disease. So we're working on those limitations. I'm just going to jump to this as a final comment. We think that some of the limitations that we have with this database, we can fix them by improving the submissions that we get in the diagnostic laboratories. We're working on getting premises IDs from the veterinarians that send samples to our laboratories in the submission forms. And then getting the companies and the veterinarians to agree to share that premise ID with the database, so that we can check whenever we get a positive, we can check if that farm was already in the database and therefore is a retest, or if it's really a new case. That will allow us to really have a database that looks at new cases and have confidence that we're looking at new cases. So there's obviously some confidentiality concerns around that, and we're working on that, but I think that's something that we want to get into to improve this database.